on the occasion of the first workshop on experimental psychopathology that is taking place in Rome from February 28 to March 1st, 2014, we are very proud to have as a special guest Professor David Clark from Oxford University. Those who are in the psychotherapy field will know certainly that the work of Professor Clark represents a landmark not only for CBT but for psychotherapy in general. His contribution has focused, among other important things, on one of the most significant innovations of CBT. He has had the merit to highlight the maintenance mechanism of some psychopathological conditions and to provide effective instruments for the therapy. Yet here a panic that bears your name. In your opinion, what have been the repercussions of this conceptualization on the history of CBT?
Well, it's one of those things where I feel very lucky because it's an article that's been cited a lot, so it seems to have had some influence on people. I think at the time it was important because the sort of psychological models were losing some of their sort of importance in psychiatry. So it was the sort of decade of the brain in America, and a lot of psychiatrists were arguing that panic was a condition that really psychology didn't have anything to contribute to. They saw it as a biological disorder, and a lot of patients were now getting drug treatments, whereas before they might have had psychological treatments. So it was very important to develop a sort of clear-cut psychological conceptualization of panic, which opened up the possibility for psychological treatments. And so I think, politically, in sort of the debate between psychology and psychiatry, biological psychiatry, it was important then. I think it was probably one of the first sort of psychological models of anxiety, which was really a clearly cognitive model rather than a conditioning model. And by focusing on the key problem being misinterpretations of bodily sensations rather than, say, conditioning, it opened up a lot of ideas. Intervention techniques they could use with that, and of course, the form of therapy that was developed from it turned out to be very effective. It did rather better than the drugs, so that was really good. I think the idea that a lot of the problem is to do with people's interpretation of their symptoms has been something which has turned out to be useful in other conditions as well. In social anxiety, a lot of a similar problem happens where people are very concerned about the meaning of their symptoms, not in terms of physical handicap, but other people seeing the symptoms and then thinking they're weird. In PTSD, it turns out that you can predict how long someone will have PTSD from the extent to which they interpret their initial intrusive memories in a catastrophic fashion. They think they're going mad or they change as a person. So I think it opened up a way of thinking about other conditions as well. Although PTSD isn't that simple, there's a lot of things to do with memory as well that you have to play in. And I guess other people have developed that sort of idea in other conditions. So Toni Morrison has a very nice model of psychosis, which is really built on the panic vicious cycle model as well. So I think it's opened up a range of different treatment techniques and allowed people to think of a purely cognitive target as something you're going to be dealing with in anxiety.
What do you think about the evolution of CBT? In particular, what do you define the third wave? It is a rift or an integration with the standard CBT? It is a breath of fresh air or a revival of well-known ideas?
Well, I think it's always a breath of fresh air when people have new ideas for therapy, and particularly when they test them out in randomized controlled trials. And I think that's true of most of the treatments that are in the third wave. So I view that very positively, I think. I think, though, the idea that it is a coherent wave is probably not correct, because I think ACT is not really the same as mindfulness, and is certainly not the same as Adrian Wells' metacognitive therapy. And I think it's probably more a way of trying to sell a movement to pull them together rather than a reality. But I think mindfulness has certainly shown its value in preventing recurrent depression. And there is a definite shift in emphasis there, isn't there? Instead of looking closely at the content of thoughts and trying to change them, it's more getting distance from the thoughts rather than challenging it. And that is, an extra dimension to therapy, which is a worthwhile one. So I see it as a worthwhile evolution. What we don't at the moment have, though, is trials showing that any of these newer versions of the treatment are better than the existing ones. So it opens up the range of therapy interventions, but I don't think it's so far pushed us forward in terms of the proportion of patients who we can get better.
Some years ago, the British government launched a mental health initiative called Improving Access for Psychological Therapy, YET.
Yes.
National Health Service, NHS, the program, the Improving Access for Psychological Therapy, hugely expanded the provision of talking therapies within the NHS, the National Health Service. Thanks to IET, NHS spent a broader budget on talking therapies. In this process, you and the economist Richard Layard had the merit to convince politicians to put money into talking therapies, and in particular to show that CBT is an evidence-based approach. Would you tell us about the story of YET?
Yes. So IET sort of started with something called NICE, the National Institute of Clinical Excellence, which is a government body which has the job of reviewing the evidence for the effectiveness of different treatments across the whole of health, so cancer treatments, cardiovascular treatments, and mental health ones. And starting in 2004, they started to issue clinical guidelines on the treatment of mental health conditions. And those early guidelines on depression and different anxiety disorders all pointed out that CBT is effective and said that it should be offered. And then, most patients weren't getting it. I think probably 2% of patients with depression or anxiety were getting an evidence-based psychological treatment. But if you ask patients, would you prefer a psychological treatment or a drug? About 3 times as many patients say they would like a psychological treatment than a drug. But in England, we were mainly giving people drugs. So we weren't giving the public what they would like, and we were denying them treatments that are effective. So that was a problem that Richard Layard and I, we happened to meet by accident. We were both elected fellows of so-called British Academy, it's a sort of academic institution, and we didn't know anyone on the day we were elected. We were just having a cup of tea next to each other, and I said, well, what do you do? He was an economist and he was interested in mental health. And he said, what do I do? And I said, well, I'm interested in mental health as well, but I work on treatments. So work, and then that would save the country some money on benefits and give them some taxes, but also they would have less physical health checks and all these other things. And when we worked it out, we said that the idea there is that the main reason why people can't get these therapies is because we don't have enough therapists. And so the program trains an extra 5,000, well, by the end of it, 6,000 new psychological therapists, and gets them to work in new treatment centres, which give CBT, but also some other therapies for people who are depressed or anxious. The government obviously wanted to know that the money was well spent, so they asked us, could we make sure we could record the outcomes on everyone? And in England, at least, often in a routine clinic, people often don't have post-treatment outcome data. Maybe they leave therapy early and you don't get the data. So we thought if we give them a measure of anxiety and depression every time they're seen, then we'll be able to see how well everyone's done. And that has worked. So we are now treating 700,000 people per year who wouldn't have had psychological treatment before, and we get outcome data on 96% of them. Yes, and at the moment 44% are recovering, so they are no longer clinical cases at the end, and about 2/3 have shown reliable improvement, so big benefits. And lots of people are getting back into work, so it does seem to be doing what we all hoped it would. And I think for us, one of the really exciting things about it is that it's all the political parties are supporting it. So in the last general election that we had three main parties: Conservatives, Labour and the Liberal Democrats, and all of them made a public commitment to expanding access to psychological therapies if they got elected. And in English political history, this has never happened before. It has never been the case that even one political party made a public commitment to mental health when it was going for election, in the national elections. But to get all of them making that commitment was extraordinary, really. And I think a lot of the reason for that is that we're able to give them the data to show that people are getting better, so they know the money is well spent.
It's a very impressive result, a very huge benefit for all the population, I think also for the government itself.
Yes, although we still have quite a way to go. So at the moment, the number of people we're seeing is about 12% of the people in England with anxiety and depression. We want to expand it to get to 25%. So we hope in the next election political parties will make that commitment, and we're asking them to do that. We also are now trying to develop these services with children, because a lot of people with anxiety problems develop it while they're still at school, and then they get less good exam results and things like that because they can't concentrate at school because of their worries. So we're trying to make these treatments available to children as well. And also, we're trying to make them more available to people who have depression and anxiety plus a long-term physical health condition, like a heart problem or problems with their breathing and things like that. And the argument is again an economic one as well as a moral one. So we have pointed out to the government that it costs the government 3 times more money to treat someone with cardiovascular disease who is depressed than someone with the same cardiovascular disease who is not depressed. And so it just allows us to run our health service more economically efficiently if we treat the anxiety and depression of people with physical illnesses as well.
Have yet now expanded in other countries?
Yes, so there are other countries that have shown a real interest in IAT. I think, politicians are always thinking, how can we get a better healthcare system without spending much more money? Mm-hmm. And IAT truly gives them ideas about that, because it says that it's an economically good thing to do, to make these treatments available. And also, we've got a system where you can see whether people get better. in Sweden and in Stockholm they have an type service running. They're all a little bit different. These are different countries and they have to do it their own way. But it's very similar to the English system. I know Canada is thinking very hard about doing something similar at the moment. The people from Denmark are doing the same, and Israel has expressed some interest as well. So I think, although they'll be all a bit different in different countries, because countries have to design it the way that fits their healthcare system, the principle is something that people have become very interested in, and I think quite a lot of other countries will do something similar. Yes.
Would you aid us to import this model also in Italy?
Well, I think it could be of great benefit here, and of course you have the strength. You have your school of cognitive psychotherapy. You've got chances to already train therapists and things. You've got a good base that you can develop from.
Thank you. Okay, we are in this workshop on experimental psychopathology.
Yes.
So I'd like to know in which way may experimental psychopathology have a role into the imposed to the evidence-based therapies.
Well, I think experimental psychopathology is incredibly important for developing efficient evidence-based therapies. In our experience of developing cognitive therapy for social anxiety or PTSD or panic, we found that we can be much more efficient in our therapy if we built on the results of the experimental psychopathology studies, which tell us what are the key maintaining factors for the different conditions. And so you can focus the therapy in a much more targeted way on what it is that's maintaining that condition. And without the experimental psychopathology research, we wouldn't have been able to target the treatment so efficiently. So I think it's very important. I think in the case of CBT, there isn't really such a thing as CBT as a single therapy. It's a lot of very different therapies for different disorders. The things we do in social anxiety, for example, have no overlap with what we do in depression, and not much overlap with what we do in PTSD or panic. It's a very specialized treatment, and that specialization has often come from the findings of experimental psychopathology studies. So I think it's wonderful that you're having an experimental psychopathology conference here. This is an area that really needs to be developed, and the fact that this conference is being put on by people who have a very strong clinical and therapeutic interest as well is the sort of perfect combination.
Thank you very much. We have finished this interview.
It's been a real pleasure to be here.
My pleasure, my honor to have this interview with you.